Good evening, respected professor and my dear students. I welcome you all to another session of DNB and academic activities on Webex platform conducted by RISA, Railway Association of ISA. I wish all our students also get involved in ISA activities. We'll be having our election for the National General Council in the first week of November, that is between 1st and 5th of November. I request all of you to actively participate in choosing our leaders for ISA so that we get right leadership to guide us for other activities, not only academic, other activities in the entire socio-political and geographical manner is also very important for the development and sustenance of our fraternity as well as growth in the right direction. So as youngsters, budding stars of future, I request all of you to actively participate in ISA activities. With this brief note, I wish to hand over the session to Professor and students. First, we'll have a Whipple's procedure, a 54-year-old man coming for Whipple's procedure, anesthesia management. Over to Dr. Muthupriya.
Good evening, everyone. Today we are going to discuss a case about a 50-year-old male with CA head of pancreas posted for pancreaticoduodenectomy. So, case presentation: a 50-year-old male who is a bank manager by occupation, present with complaints of loss of weight and appetite for 6 months. He had yellowish discolorization of eyes and urine for 3 weeks, clay color stools for 3 weeks. History of presenting illness: a 50-year-old male who is apparently normal 6 months back had noticed a loss of weight and appetite. He had yellowish discolorization of the eyes and urine for the past 3 weeks, with this insidious in onset, gradually progressive in nature. History of generalized itching is present. History of clay color stool is present for the past 3 weeks. No other history, no history of abdominal pain, fever with chills, abdominal distension, nausea, vomiting. Passage of dark color stools. Past history: he is a known hypertensive for 10 years on tablet clinidipine 10 mg. No history of diabetes, CAD, CKD, thyroid issues. No history of TB, asthma, epilepsy. No history of similar complaints in the past. No past surgical history. Family history: no significant family history. Personal history: he is on mixed diet. Loss of appetite is seen. Normal bowel and bladder habits. Normal sleep pattern. He is not habitualized to smoking and alcohol. Examination: he is moderately built and nourished, weight about 52 kg and height about 160 centimeter, BMI about 20.3. He is afebrile, conscious oriented. Icterus is seen. No pallor, cyanosis, clubbing, lymphadenopathy or pedal edema. Vitals: his heart rate is about 92 per minute. The right radial, normal volume or character, no vessel wall thickening, no all the peripheral pulses are felt. BP is about 140, 80 mm in the left arm sitting position. Respiratory rate is about 20 per minute, abdominothoracic type. Local examination: scratch marks are noted all over the arms, abdomen and chest. There is no sign, like stigmatas or signs suggestive of chronic liver failure. There is no goiter. Spine is palpable. IV axis is good. RV assessment: there is no obvious facial deformity. Mouth opening is about more than 3 fingers. Mallampati grade about 2. Upper lip bite test class 1. Thyromental distance more than 6.5 centimeter. No restriction of neck movements. Systemic examination: cardiovascular, yes, first and second heart sounds are heard. No murmur. Central nervous system: no focal neurological deficit. High mental function normal. Respiratory system: bilateral RNG, chest is clear and normal vesicular blood sound. Abdomen: the patient is on supine position with arms to the side. Inspection: it has normal contour, flat abdomen with umbilicus inverted and centrally placed. All the quadrants moves equally with respiration. Scratch marks are noted. No distension or visible pulsation or dilated veins. No previous surgical scars. Palpation: no warmth or tenderness. Low water of liver is palpable with respiration below the right costal margin. It is firm and regular in consistency. No other palpable mass or organomegaly. Percussion: there is no shifting dullness. Liver dullness is noted at the fifth intercostal space mid-clavicular line. There is tympanic node noted. Auscultation: normal bubble sound. No venous hump or arterial bruit. Summary: a 50-year-old male came with complaints of painless progressive jaundice with loss of weight, appetite, and generalized itching. Investigation. We look into the CBC. In CBC, we look into the hemoglobin, total count, and platelet. Hemoglobin to look for any anemia due to any malabsorption or blood, or to look at the hemoglobin as this is a major surgery. Total count, there will be active infection or sepsis due to endotoxemia in obstructive jaundice. Platelet to look at the coagulation profile. LFT, serum bilirubin, we look into the direct and indirect bilirubin, and to rule out whether it is a conjugated, whether it is a pre-hepatic or hepatic or post-hepatic cause of jaundice. We look into the liver enzymes like AST, SGOT, SGPT, aldehyde, GGT, and alkaline phosphatase. Serum albumin is noted. Total protein, serum albumin, and globulin is noted to look for the synthetic function of the liver. RFT like serum urea creatinine, electrolytes like sodium, potassium, bicarb, to rule out renal function and to rule out hepatorenal syndrome. Coagulation profile like PT-INR should be noted to rule out coagulopathy. Viral markers, chest X-ray and ECG is done. CCT and ultrasound should be done to look for the cause of obstructive jaundice. Echo should be done if the patient is having poor effort tolerance or if he has a concentric aldehyde state or the patient is symptomatic. After proper investigation and diagnosis, the diagnosis is confirmed and the patient is posted for surgery. Before surgery, proper pre-op counseling should be done to reduce the anxiety. As Whipple's is a major surgery, ERAS protocol can be followed. Informed consent should be obtained. We should explain the procedure and anesthesia. We prefer general anesthesia with epidural anesthesia. Fasting guidelines, we can take clear fluids up to 2 hours prior to surgery. Carbohydrate drink like Carboload 12.5% maltodextran is given just 2 hours prior to surgery. It reduces the insulin resistance, decreases thirst, fatigue, or hunger. It also decreases the gastric volume and pH and maintain the blood sugar. About 50 gram of maltodextran in 400 ml NS is given 2 hours prior. It is given in patients who are not diabetic. Pre-medications like prokinetics, proton pump inhibitors like metoclopramide and pantoprazole is given night before. An anxiolytic like tablet Alprax 0.5 mg can be given. After and the major anesthesia concern in Whipple's procedure is a surgery later. As it is a prolonged surgery, it takes about 7 to 8 hours, and with blood loss and fluid and electrolyte shift occurring during the surgery. So pre-op OT setup with airway, emergency drugs, suction, machine check, ambient room temperature should be there. A warmer, artery line, epidural kit, DVT stocking should be kept prepared. We should take the patient in. Standard ASA monitorings like ESD, pulse oximeter, NIBP should be done, and baseline vitals are noted. 2 large IV bore cannula can be inserted, one before induction. The patient should be catheterized. An artery line can be placed to monitor BP if there is a major fluid shift or electrolyte imbalance, and lactate to look for tissue perforation and for ABG sampling also. Antibiotic prophylaxis should be given. Then after that, the patient can be epidural anesthesia should be given. It is given at the level of T8 to T9 under local anesthesia. It is mainly given for intra post-op analgesia. A test dose of 2.2% ligno area, 3 ml should be given. If there is a 10% rise in heart rate within 2 minutes, then it is intravascular. If there is a loss of sensation to cold, like within 5 to 10 minutes, then it is epidural. And if there is a motor blockade after 10 minutes, then it is spinal. Induction and intubation. We should pre-oxygenate for 3 minutes till the ETO2 comes more than 90%. Fentanyl about 2 mics per kg should be given. and lubricant to reduce the stressor response. Propofol is given at a titrated dose. Propofol is preferred because it is extrahepatic. It has an extrahepatic metabolism and rapid clearance. After check ventilation, atrac or 6-atracurium is given, as it is eliminated by Hoffman's elimination. Then the anesthesia is maintained with air and iso or sevofluorine. After that, patient is intubated with the 8-size ET tube, and after 5-point auscultation, the tube is secure. A central line can be placed. A central line can be placed for if there is any need for any vasopressors, or to look for CVP to assess the fluid trend of fluid status, and for sampling also. Introp, we should look for we should watch for hypothermia. Adequate analgesia should be given intraoperatively. CPG monitoring should be done. Since it's a major surgery, we should look into the maximum allowable blood loss, and fluid management should be done. Goal directed fluid therapy with balanced salt solution like ringalactate should be given, and we should look for the, as it's a major surgery, open surgery, that is third phase, more of third phase loss. We should give fluid therapy according to that. The patient can be extubated if the patient is hemodynamically stable and the ABG is normal, there is no ongoing bleed, there is adequate muscle power, normothermia, and the patient is taking good efforts. Post surgery, we should look for post-op complications like anesthetic leak or fistula. Early mobilization should be done and chest pressure deep breathing exercise should be given. Effective analgesia is important for post-op respiratory function and for the compliance of physio, mobilization, and prevention of complication. It reduces the surgical stress response. Thank you, sir.
Okay. Can you read the case scenario given again, please?
Yes, sir. A 50-year-old male with the CA head of pancreas posted for pancreaticoduodenectomy.
Duodenectomy. Okay.
Yes, sir.
And you have presumed that patient is jaundiced. Is it always necessary that the patient will become jaundiced if they have a CA head of pancreas?
If there is head of pancreas obstructing the pancreatic duct and...
No, the question is very clear. Yes or no? Is there a need for the patient to become jaundiced in all cases of cancer head of pancreas or not?
No, sir.
Not necessary, isn't it?
Sir.
So the first classification you have to make is, we do not know whether the patient is jaundiced or not.
Okay, sir.
Okay. And the procedure has been already given, pancreaticoduodenectomy.
Yes, sir.
Okay. So that means it's the head of the pancreas or the CA pancreas. Commonly it can be, should it be always in the head only? What are all the anatomical description of a pancreas? What are all the, how is pancreas described having the subset of pancreas?
Head, neck, body, tail, and uncinate process.
Uncinate process. So pancreatic tumor can be, or carcinoma can occur anywhere. It can be
Yes,
in the head. Commonly it happens in the head. Sorry. But it can happen in the neck and body or the tail also. Okay?
Yes, sir.
So that is another vague thing which we are not aware of from the clinical scenario that has been given. Okay?
Yes, sir.
So that is the second dilemma or the information that you would like to require. Which part of the pancreas is affected by the cancer? Whether it is causing an obstruction by occluding the ampulla of Vater.
Yes, sir.
To produce jaundice in this patient, and whether the surgery, the surgeon is going to be done as a, is it open surgery all the time?
It can be done laparoscopically.
Laparoscopically also. What are the indications to do it laparoscopically?
Vascular anatomy, if there is no vascular invasion, and it's size of the tumor, sir. If it is small,
smaller the size of the tumor, or more in the tail region rather than
yes,
the head and the body region. Okay, those have So that also we do not know where it is given only CA pancreas. We do
Head
not
of
know.
pancreas.
So this sort of vague clinical scenarios, it will be better if you discuss in your theory answer
Okay,
all
sir.
the possibilities of things which that has not been given in the case scenario. So the
Okay.
first thing is we do not know whether the patient is jaundiced or not. The second thing is we do not know the location of the cancer, whether it is in the head or the neck or body or tail. Third, we do not know whether the surgery is planned by open method or by laparoscopic method. And the fourth thing is, you said the patient is a known hypertensive.
Yes, sir.
That also you have presumed for
Yes, sir.
discussion's sake. But if supposing the patient is a known diabetic and he
Yes.
develops a pancreatic cancer, what will be the change that will happen in his diabetic state? Will he become more diabetic or less diabetic?
Less diabetic, sir.
Why?
Pancreatic tumor cancer that is insulin resistance, sir.
Insulin resistant means the sugar will go up or come down.
Go up, sir. Sorry, sir.
There are two methods where the diabetic state will get escalated. That is, the sugar values will go higher up for two reasons if there is a pancreatic cancer. One is there may be an obstruction to the release of insulin because the tail of the pancreas, which is where the insulin secreting cells are there. What are the cells which are present in the tail of the pancreas, which are mainly secreting the insulin in our body?
Islets of Langerhans.
Cells of the islets of Langerhans, which are
Yes.
situated mainly in the tail of the pancreas, not in the head or back. What is the role of head, neck, and body of pancreas? What is the function? That produces more of digestive enzyme, pancreatic
Pancreatic
juice.
juice.
Okay? That is
Exocrine and
produced
endocrine.
mainly from the head, neck, and the tail, and in the
Yes.
body. The tail is mainly consisting of the islet of Langerhans cells, which secrete the insulin. Okay.
Yes.
So the insulin production may be affected if the islet of cells are replaced by the cancer cells. Do you think more insulin will come or less insulin will come?
More insulin, sir.
Huh?
More
Islet
insulin.
cells are replaced by the tumor cells.
Then less insulin, sir.
Less insulin will come. So
Yes.
one of the diagnostic things, patients who are long-term diabetics, in spite of heavy oral and insulin, if their blood sugars are not coming under control, it is always remaining 300, 400, 450. You have to suspect by the CA pancreas, especially in the tail region, which is preventing normal secretion of insulin.
Okay, sir.
A relative of mine was treated only at Mayo Hospital. And she passed away 2 years ago. Her main problem was she was a known diabetic for 12 years. And suddenly her sugars started going up violently, like with 400, 500. And the diabetologist who was treating her, it simply escalated the dosage of oral anti-diabetic drugs initially. It was not coming under control. Then he advised her to go for insulin twice a day. And then he increased the dose to thrice a day or 4 times a day. And still the sugars were not coming down at all. And then she went and met a gastroenterologist who asked to take a near ultrasound, and it proved there was a pancreatic tumor in the tail of the pancreas. And then that tumor, by the time it was diagnosed, grew and spread to the head and all. And the CT and MRI proved that it is inoperable. And by the time it started obstructing the ampulla of Vetter, and she became jaundiced also. And they have to put a stent in Miyot only for relieving the jaundice because the obstruction was so severe. And gradually, with chemo and radiation, she was surviving for almost 2 years, then passed away. Okay? So this is another problem that you have to keep in mind, that uncontrolled diabetic state indicates that tumor may be in the tail of the pancreas also.
Okay, sir.
So all these vague questions are there. So with that in mind, we have to discuss if the questions does not give a clear picture about the whole state of the patient. But
Yes,
if the same case scenario is given in the viva for you to discuss, then you can ask the examiner or you can discuss with the examiner, sir, here we do not know whether the patient is jaundiced or not. We do not know the location of the cancer in the pancreas. And we do not know whether the surgery is planned by open, where they have to do a total pancreatectomy or a resection of the head alone and go for Whipple procedure, because pancreaticoduodenectomy means it is a sort of Whipple procedure only. So
yes,
it is a resection of the head, and so you are not at fault for assuming that the patient may be jaundiced with a obstructive feature. Okay?
yes, sir.
And you have cleverly included that patient is having eye-colored urine and clay-colored stools. Okay,
Yes,
to
sir.
thus, establish or prove that it is an obstructive jaundice. Okay, but one thing that you notice that you said the pulse rate is 92 and BP 140, 80.
Yes,
Do
sir.
you expect the pulse rate to be 92 in a patient with obstructive jaundice?
No, sir. Because due to increased bilirubin, the bile salts get accumulated and can act on the SA node and cause sinus bradycardia. And yes, sir.
So normally you expect only a bradycardia.
Yes, sir.
And what is the effect of high bilirubin on the vascular tree?
That is a decrease in contractility, sir. And decreased response to the vasopressors.
Catecholamines, endogenous catecholamines as well as
Yes, sir.
vasopressors. Okay. So high bilirubin level causes both reduction in inotropic effect on the heart as well as reduction in the response to the catecholamines on the vasculature also. Okay.
Yes,
so a pulse rate of 92 is not clinically acceptable if it is
yes,
a true jaundice with a high bilirubin value. Okay, so
yes,
when
sir.
you say the parameters, you have to be little careful in saying. If it is a real patient and you are counting 92, that is a different question. But
Yes,
if it
sir.
is a imaginary patient and you are giving the parameters, you have to think in times that normally they have a pulse rate of between 50 to 60, not more
Okay.
than that. And a very high pulse rate in a severely jaundiced patient, what does it indicate? In case your real patient has a pulse rate of 90 or 100,
Maybe
is it
failure,
of
sir.
significance?
Failure.
Maybe patient is in failure. Okay, that is the indication that patient. So, what other systems can be affected by chronic elevated bilirubin, as you see in this case?
Elevated bilirubin, sir.
Yeah, see, obstructive jaundice,
Yes.
you have a very high bilirubin values. Right?
Yes, sir.
What are the
It
effects
has
on the cardiovascular system? What is the effect on the central nervous system? What is the effect on the renal system? What is the effect on the immunology?
in the renal system, due to increased bilirubin, it causes acute tubular necrosis of the kidney and causes ischemia, sir. If there is more of unconjugated bilirubin, it can cause kernicterus in hemolytic disease of newborn, causes kernicterus in CNS, sir. And
we are not discussing in newborn and all.
Okay, sir.
With respect to the case scenario that is given to you, if this
Yes, sir.
patient's bilirubin is 5 milligram or 6 milligram,
Yes, sir.
what are all the possible effects on the cardiovascular system, central nervous system, renal system, and the immunology?
Central nervous system, like GA system, that can be malabsorption. And the fat soluble vitamins like A, D, E, K will be deficient, and due to that, vitamin K absorption, clotting factors like alpha carboxylation of the clotting factors like 2,799 won't happen, and there will be deficiency of clotting factors, and leading to coagulopathy. There is a decrease in depression of the reticular endothelial system, sir. So impaired T cell proliferation, decreased neutrophil hemostasis will be there, sir. And
anything other than the malabsorption and lack of absorption of fat soluble vitamins, any other thing in the gastrointestinal system which is of importance?
The barrier, endothelial lining barrier will be
Endothelium
defective.
or
Intestinal mucosal barrier will be defective. So endotoxemia, that is translocation of bacteria, can lead to subbacterial peritonitis, sir.
Peritonitis or sepsis. Okay,
Yes.
Blood also can get infected and it can get a sepsis. Okay, that is a very important point. And with regard to cardiovascular system, already we have seen decreased inotropic and vascular dilatation leading to hypoperfusion, and gradually patient can go in for cardiac failure also.
Yes, sir.
And renal system, there can be renal
vasoconstriction and
this hypotension also may affect the kidney function. Okay?
Okay, sir.
And immunologically, patient is more susceptible for that. What is the effect on the liver if there is an obstruction to the flow of bile?
Due to biliary outflow tract obstruction, there is increase in back pressure to the biliary system, sir. So it causes cirrhosis of the liver, sir. Due to
cirrhosis. Will it lead to straightaway cirrhosis, or initial changes have to be like inflammatory stages? Ascending cholangitis.
Yes, sir.
Will produce ascending or retrograde cholangitis.
Okay, sir.
Which will produce a pro-inflammatory state, which will lead to gradual replacement
hepatic fibrosis
tissues, which will lead to cirrhosis. Okay? That's all a little long-term effects on the liver also. Okay? So these are all the points that you have to keep in mind. And with regard to the surgery, you said it's a 6 to 8 hours surgery. So patient has to be and it can be done by ERAS protocol or regular non-ERAS protocol also. That's another point we have to. So we have to have a good dialogue with the surgeon before you plan to give anesthesia for a Whipple procedure, where all these questions have to be answered. Whether you are going to do by lap method or are you going to go to by open method, whether you are going to follow ERAS protocol or whether it is going to be non-ERAS protocol. And if the patient is jaundice, is there any need for relieving the jaundice if it is very severe by any procedure?
Yes, sir. ERCP can be done, sir.
ERCP or stenting can be done to temporarily relieve the obstruction and increase the blood flow, bile flow into the intestines. So these points have to be discussed before you do the case. Otherwise, the management is usually with a GA with epidural. That is the conventional method of managing these cases. And the epidural must be mid-thoracic epidural.
Yes.
Okay. So, in the epidural, do you give always only local anesthetic, or is there a substitute for that?
Opioids can be given.
What is the advantage of giving opioids in the epidural space rather than giving local anesthetic?
Opioids will stay for morphine can stay for a long duration and won't cause significant hypotension compared to the local anesthetics.
Okay. So if there is hypotension due to local anesthesia, what is the risk involved in the administration of local anesthetic epidural to this patient?
Due to hypotension, we try to give more fluids and can lead to volume overload, sir. And there will be intestinal edema, bubble edema, and later lead to paralysis, ileus.
Ileus and anastomotic leak is more common.
Yes, yes.
The sutures will try to give way, and it may be one of the causes of anastomotic leak. So you have to go for, you mentioned about goal-directed fluid therapy.
Yes.
Is there any other alternative to that?
Restrictive fluid therapy.
Restrictive fluid therapy. What is the difference between restrictive fluid therapy and goal-directed fluid therapy? Restrictive, you blindly restrict the fluid.
Yes, sir.
Okay, instead of giving large volumes of fluid, even if there is a hypotension, you use vasopressors to counteract the hypotension and restrict the fluid to maximum of 4 to 5 pints for the entire 7 to 8 hours of surgery. Whereas in goal-directed fluid therapy, you have to use extra monitoring like stroke volume variation, pulse pressure
Pulse pressure
variation. You have to use the Vigilo monitor and high sophisticated monitors to find out the exact response of the vascular tree and the fluid status, and then administer the fluid. That is the difference between goal-directed fluid therapy. In goal-directed, you need all extra monitoring,
Okay,
like
sir.
what we discussed in the earlier classes before people went for exam. The pulse
Yes.
pressure variations, so dynamic and static indices have to be studied to
Okay, sir.
adjust your fluid level. Whereas in restrictive fluid therapy, you just simply restrict the amount of fluid and maintain the mean arterial pressure with the help of vasopressors rather than rushing in fluid to maintain the MAP. That is the major difference between these two. Okay.
Okay, sir.
So this is how you have to manage the whole case scenario.
So irrespective of urine output, sir, like the urine output.
Urine output, you have to have a minimum of 0.5 ml of urine per hour. So that is
Okay,
a
sir.
very important thing to maintain. And with this 4 to 5 pints, you will have definitely at least minimum 0.5 ml per kg per hour will be there, provided you maintain the MAP with vasopressor to all the time without allowing prolonged periods of hypotension.
Okay,
So
sir.
if that is avoided, definitely the kidney will not be affected. There is always a debate whether to use mannitol in cases of severe jaundice patient coming for any surgery. Even if say there is a common bile duct obstruction because of a stone, and they want to do a CBD exploration and remove the stone and put a stent, that patient also may require anesthesia. At the time, there is a chance that patient can go in for post-operative renal shutdown or kidney failure. So earlier teaching was it is better to flush the kidneys with mannitol given from the pre-operative state at the rate of 0.25 grams per kg, that is 250 milligram per kg per hour, as a both as a diuretic, osmotic diuretic effect, as well as the another advantage of mannitol it is it causes the removal of the reactive oxygen species, and it saves the cells from the effects of the so-called what is that related to reactive oxygen species, that is
Super
what is called superoxides and all the other harmful uh, uh, elements from the blood. So that is another scavenger of these free radicals. That is the word that they use. So mannitol helps in scavenging the free radicals as well as causing osmotic diuretic to keep the kidney in a diuretic phase, which is supposed to prevent an acute renal shutdown happening in these patients. But that has been questioned now, and so people, because once you give mannitol, you will be dehydrating the patient. So here then you have to challenge the to maintain mean arterial pressure at the normal level. You have to give more fluids. That will defeat the purpose. So that is why people don't advocate giving mannitol now. Then people change to giving Lasix or furosemide, 40 to 60 milligram, to keep the kidneys in a good diuretic functional state. But that also causes dehydration or removal of fluid from this vascular tree, which again is contradictory to maintaining a restrictive fluid therapy that will affect the mean arterial pressure. So both the things have now been debated and not accepted. Giving mannitol as well as furosemide is not accepted completely, and the only thing that is allowed is using a restrictive fluid of not more than 2 to 3 liters during the entire procedure of surgery arbitrarily, or go for as you said, goal-directed fluid therapy with more advanced hemodynamic monitoring. So we'll just see some slides on that. There is a good article on the anesthesia tutorial of the week. So WFSA, World Federation of Society of Anesthesia. There is an article on it just mentions pancreatic surgery, not it doesn't stick to Whipple's alone or pancreaticodorectomy. It mentions totally, but most of the points are applicable to the pancreaticodorectomy surgery also. So we'll just see what is the thing that is given in. I have prepared it as a question and answer type so that you can answer that in the slide visible.
Yes, sir.
Okay. So this is the title given there: perioperative management and anesthetic considerations for pancreatic dissection surgery. Okay. So the first thing is anatomy and physiology of pancreas. We have already seen pancreas has got a head, a neck, a body, a tail, and an uncinate process. Okay. So what does that uncinate process mean? What is the meaning of uncinate? Where else you have this uncinate word? Which other organ in the body also has this word uncinate being used?
Brain.
Brain, yeah, you have an uncinate gyrus, isn't it?
Yes,
You have a brain, you have an uncinate gyrus. And the meaning of the word uncinate is it is like a hook or a barb. Okay, so that is the meaning of the word uncinate. So the pancreas is divided into head, neck, body, and tail. Of course, uncinate is also there, but even these four parts is, and it has a secretory organ with both endocrine and exocrine function. And the endocrine is the, what are all the endocrine functions of pancreas?
It secretes insulin, glucagon.
Glucagon, then?
Yes, sir. Polypeptides, pancreatic polypeptides.
Pancreatic polypeptides. So parenchyma is made up of acinar cells. So exocrine produces the digestive proteolytic enzymes.
Pancreatic juice.
And amylase is the main enzyme that is contained in the digestive tube. And endocrine cells of islet of Langerhans, they produce insulin. And the A cells produce glucagon. And B cells and F cells produce the pancreatic polypeptide. So these are the endocrine functions. And the main function is to aid digestion and blood glucose control by secretion of insulin. These are the two main functions of pancreas. And if you see the anatomical picture, this is the head, neck, body, tail, and this is the uncinate. You can see that is serving like a hook from the undersurface of the head. That is why it is called the uncinate process or uncinate part of the pancreas. And the common bile duct and the pancreatic duct, they join together and open in the which part of the duodenum?
Second part of duodenum.
Second part of the duodenum, which is covered by a sphincter-like thing called the ampulla of Vater. So that is how the whole anatomy is there. What are the pathological conditions which affect the pancreas?
Acute and chronic pancreatitis, sir. Tumors, neuroendocrine tumors, diabetes.
Okay, so it can be inflammatory, it can be malignant, which it can be benign tumor, diabetes mellitus, and congenital conditions. So acute and chronic pancreatitis is an inflammatory condition. Malignant pancreatic tumors can be of exocrine origin, which is an adenocarcinoma, or it can be neuroendocrine like gastrinoma, gluconoma, insulinoma, etc. And tumors of malignant potential, which are not directly malignant, but which can turn malignant anytime. Intraductal papillary mucinous neoplasm and cystic neoplasms. And benign tumors are serous cystadenomas. Diabetes mellitus can be of two types, type 1 and type 2, congenital annular pancreasis or pancreatic divisor. Now, what are the features of pancreatic carcinoma? How will you diagnose clinically and then by investigation pancreatic carcinoma? You already, what is the history you elicited from the patient?
Obstructive jaundice, painless obstructive
Patient
jaundice.
does not say obstructive jaundice. What are the initial things you said about the patients?
Loss of weight,
Loss of appetite, weight loss, that is how you started, isn't
Yes,
it?
yes,
So,
yes.
non-specific abdominal pain, jaundice are both present, unexplained weight loss, steatorrhea, gastric outlet obstruction due to tumor compressing the duodenum or stomach may result in nausea and early satiety. Okay? Patient says, I feel very full even if I eat little, and if he has a very severe jaundice, pruritus also will be there. What is Carboyceous sign?
That is palpable gallbladder in the absence of
Painless jaundice.
painless jaundice. Yes.
Okay. So palpable gallbladder in the absence of painless jaundice is called Carboyceous sign. What are the risk factors for developing pancreatic carcinoma?
Alcohol, smoking,
Alcohol, smoking, age. Okay. Raised body mass index. Obesity is also one of the causes. Diabetes mellitus, chronic pancreatitis, family history, associated also with familial cancer syndromes, inflammatory bowel disease, septic ulcer, and periodontal diseases. All these are risk factors. How is this condition diagnosed? How do you make a diagnosis?
ultrasound or CCT.
Yeah, from the first you suspect from the history, you can suspect maybe it is a carcinoma, but confirmatory diagnosis is by full blood count to reveal normochromic anemia, thrombocytosis, or both. Then elevated serum bilirubin if there is an obstruction, especially the conjugated one, and total bilirubin will be high. Then there will be increase in alkaline phosphatase levels and G-glutamyl transferase if jaundice is present. All these enzymes also will be elevated. And tumor marker CA19-9 is a very pathognomonic and characteristic identifying thing for CA pancreas. And you can do ultrasound, CT scan, then endoscopic ultrasound and PET scan for primary and metastatic spread. These are all the investigatory tools that you have. What are all the modalities of treatment of cancer pancreas?
Depending on his severity, we can give a neoadjuvant or adjuvant chemo radiotherapy, and following that surgery, and palliative supportive treatment alone.
Surgery is supposed to be totally curative. If you can
Yes,
resect the entire tumor before it spreads to outside areas, that is a direct curative potential. And alternatives to that are patients who are not willing for surgery or medically unfit to undergo major prostatic surgery. They may have systemic chemotherapy, chemoradiotherapy, or simple surgical bypass or ablative therapies, and gastrointestinal and biliary stenting to relieve the jaundice. Okay, these are all the palliative treatments that you can think of. What are the surgical approaches for pancreatic surgery?
Whipple's procedure,
Approach, not the
open or
open or lap. That
laparoscope.
Can be open or laparoscopic approach. What are the indications and advantages of lap pancreatic surgery?
Indication for tail of like small tumors.
Small tumor and
tail of pancreas.
Pancreas. Okay.
Advantage,
So,
minimal incision,
Very
early discharge, and minimal
good.
post-op
Shorter time
complication.
to oral intake and shorter hospital stay. And what are the types and indications for advantages and drugs used in chemotherapy for treating pancreatic cancer?
Gemcitabine is used for chemotherapy. Gemcitabine and platinum, cisplatin drug group of drugs are
Platinum
used.
combination, or it can be used as a neoadjuvant, that is, you can give before surgery if the tumor is very large to reduce the size before you take up the patient for surgery, or it can be given after surgery to prevent recurrence or spread. Okay, so that is the types of chemotherapy: neoadjuvant or adjuvant therapy. And the metastatic PC, it can slow down the growth of the tumor and offer symptomatic relief along with radiotherapy. The most commonly used drugs are a combination of two drugs, gemcitabine and cisplatinum, with or the other combinations used nowadays, newer combination is FOLFIRINOX and Abraxane. These are the four drugs that you have to remember. What are the structures? What structures are resected and what anastomosis are performed in pancreatic or duodenectomy? It is the pre-procedure.
The head of the pancreas, pylorus of the stomach, CPD and gallbladder, and the anastomosis like hepatojejunostomy, gastrojejunostomy, and duodenojejunostomy. The anastomosis.
So this is the picture will show you. You remove the gallbladder, you remove the duodenum part of the duodenum, the stomach part, the distal part of the stomach, and part of the head of the pancreas. All these things which are given this gray color, all these things are removed. And then you do the anastomosis between the stomach and duodenum. All are attached to jejunum only, because that is a long segment. So gastrojejunostomy, hepaticojejunostomy, and pancreaticojejunostomy. So that is how the three anastomoses are done. What is the pre-op management of patient? How do you, how do you manage this patient pre-operatively? What are the steps in the pre-op management?
Optimization of the patients.
Optimization. First, risk stratification. Any surgery, as I showed you here, you can do a risk stratification, looking at the other possible things, using the POSUM score. And the second thing is correction of anemia. These patients are invariably having a normochromic normocytic anemia. So that should be corrected with iron, folic acid, and B12 supplements. And preoperative counseling helps to diminish anxiety, enhance postoperative recovery, early mobilization, feeding, and pain management. It is more so if it is a ERAS protocol is going to be followed. This is very, very important. And smoking and alcohol cessation for at least 1 month prior to the surgery is very beneficial. And patient is malnourished, nutritional supplements and enteral nutrition to be done to correct them. Now the static testing that you can do in these patients can do NT-proBNP. Why it is indicated?
To know about the cardiac status of the patient.
Some patients have cardiac failure preoperatively. CA pancreas patients, especially with severe obstructive jaundice, they may have cardiac failure, which can be quantified by assessing this. Then you can do an echocardiography, and postoperatively you can do a troponin also to assess whether there is a cardiac damage due to the stressful surgery that they have undergone. The dynamic testing that you can do in them are cardiopulmonary exercise testing. If they have features of mild cardiac compromise, then you can do a CPT, or you can do a dobutamine stress echocardiography. But from the regular resting echocardiography, this will give you the correct status of the cardiac function. Now, if ERAS protocol is possible, is it possible in pancreatic surgery? If so, what are the advantages of that?
Yes, sir.
ERAS can be practiced in very small tumors and distal part of the pancreas. So it is possible only for such cases, but for major resections and anastomosis, it is not a suitable protocol. Okay.
Okay, sir.
So if it is possible, then it has a benefit of short hospital stay, early feeding, which we all saw, and it requires a multidisciplinary team. It is crucial to determine the suitability for surgery. The patient should be well informed about that. That is what called the prehabilitation. You tell the patient what is expected out of that, and then the potential complications are also discussed before you make a decision. And preoperative carbohydrate drinks are recommended in patients who are not diabetic. That's a very important point you must always mention there, because as I said earlier, diabetic patients whose blood sugar become very vulnerable and fluctuating and very high, they may be coming for surgery. So in such patients, giving preoperative carbohydrate drinks will definitely elevate the blood sugar too high beyond the normal values or accepted values. So you must always mention the adjective that it is recommended only in patients without diabetes. What are the likely complications of this surgery? So you can have unique set of conditions like three anastomosis are there, so it can produce complications like ileus, anastomotic leak, or pancreatic fistula formation. These are the three important complications because of the surgery. Now, what is the importance of intraoperative and post-op analgesia in pancreatic duodenectomy, and how it is provided? What are all the options that you have?
For early mobilization and better chest physiotherapy.
No. What are the methods of providing this?
Epidural, we can give an
early mobilization and good breathing and less complications of atelectasis or respiratory and other complications are less. That is the idea of any good analgesia. Okay, but what are the methods by which you can provide this analgesia?
We can give an epidural.
Epidural, thoracic. Let's say the level. Don't just say, because this has to be. This is upper abdominal surgery involving the thoracic segment. So you must say whether it is high thoracic or mid thoracic or low thoracic. So this is usually mid thoracic epidural analgesia. Then
about T6 to T8, sir.
Okay, right. That is one option. What are the other options?
Blocks. Like a tap block or a erector spinae block.
Tap block, will it give a visceral pain relief? It may give the somatic superficial pain relief. The tap block is not good for visceral pain relief.
Okay, sir. Local infiltration.
Whereas your paravertebral blocks are more effective in that way rather than your tap block alone. Okay?
Erector spinae block.
Erector spinae or paravertebral block.
Yes, sir.
So effective analgesia is important for post-op respiratory function, compliance with physiotherapy, mobilization, and prevention of other complications like due to prolonged bedridden state. Different analgesia strategies are different for open and laparoscopic surgery, because if it is done laparoscopically, minimal skin ports are only put, so there is not much of pain in laparoscopy. That is the advantage. So the analgesia has to be decided on the pattern or approach, whether it is open or laparoscopic. So mid-thoracic epidurals for intra and post-operative pain relief is the most commonly practiced one. And even that thoracic epidurals associated with superior post-operative analgesia, reduced stress response, decreased need for opioids, and pulmonary and cardiac morbidity, early return of intestinal function, and reduced thromboembolic complications. These are the advantages. But giving local anesthetic, as you said, may cause hypotension, which may require or which may be mistakenly treated with too much of fluids, which will cause unwanted complications. So for upper transverse incision, epidural catheter should be inserted between T5 and T8 root levels. So the It may the Whipple's procedure, you may have seen in your hospital, may be done by a upper paramedian or a transverse incision. Bilateral subcostal incisions are also made, isn't it? So that is how the surgery is done. So the level should be adequate. And post-operative pain can be managed with patient-controlled analgesia with opioids. And you can, in case regional is not adequate, then PCA also will help in giving post-op analgesia. And you can use single shots intrathecal spinal opioid, which may provide good analgesia for both laparoscopy and open pancreatic surgery. So subarachnoid morphine or buprenorphine they have been practicing, which will give pain relief up to 12 to 18 hours post-op intraoperatively. And intravenous bolus ketamine and followed by lignocaine infusion also have been tried as analgesic adjuvants. Okay, that is another thing. So you give a single first bolus dose of ketamine, follow it up with lignocaine infusion for the entire surgery, which also is one of the recommended things. And how fluid therapy is managed, we have already seen, and what factors affect the fluid therapy. Neutral fluids like balanced salt solution should be given. Avoid normal saline. And restrictive fluid administration is recommended rather than going in for liberal fluid, which was done in the earlier days. And chemoconcentration and raised lactate levels indicate inadequate fluids. So if you think when you practice restrictive fluid therapy, if you think the fluid infusion is not adequate, then if you do a lactate assessment during the procedure itself by taking the blood sample, and if there is a chemoconcentration as a raised PCP, the hematocrit, then you will know that patient's fluid status is not adequate, and you can use that as a guide for fluid resuscitation. So this is only indicated for the empirical restrictive fluid therapy. Whereas for goal-directed fluid therapy, as I told earlier, you can have advanced monitoring with stroke volume variation and pulse pressure variation, and try to adjust the fluid that you want to give. Then the mixed venous saturation can be used to determine adequacy of perfusion of the tissues. So where will you do the mixed venous saturation assessment?
Pulmonary artery catheter.
Pulmonary artery catheter. We have to go that far.
CVC.
Of course, you can do that from pulmonary artery catheter also, but normally do you put a central line? Yes, central line directed towards the upside. Instead of going towards the heart, if you go in the reverse direction, then you can get a jugular venous saturation, which will tell you the correct perfusion. If the extraction is more, what is the normal oxygen level in the venous blood?
75%.
75. So if it is 60, what does it indicate? More oxygen is being extracted. So that is the importance of this mixed venous saturation assessment. And it can be complicated by epidural analgesia with local anesthetic, which can cause hypotension. And that to correct that, you may cause Russian fluids, which loses the formation of pancreatic and biliary anastomosis, may go unnoticed also. Another losses that happen because of the resection and anastomosis also is a reason for patient becoming hypovolemic, other than the hypotension that is caused or vasodilatation caused by the local anesthetic. Central venous pressure was earlier thought of guide to fluid therapy, but that is not now completely accepted, because under general anesthesia with IPPV intubation, the values are not correlating with the normal respiration where there is a negative intrathoracic pressure. So CVP values are earlier thought of as a good guidance for fluid therapy, which is not accepted now. What are the other complications needed to be averted during surgery?
Electrolyte imbalance.
Electrolyte imbalance. First and foremost is hypothermia. Okay, avoidance of hypothermia. Then treatment of hyperglycemia. Patients may become hyperglycemic, which may require good correction with insulin infusions. And you should give antibiotic prophylaxis, including repeat dose during prolonged surgery. Okay, these three things you have to remember: hypothermia, hyperglycemia, and antibiotic prophylaxis and repetition of antibiotics during prolonged surgeries. What post-op care to be provided and why? Early mobilization should be encouraged from the first post-operative day to meet daily targets as part of enhanced recovery, as well as enteral feeding should be commenced within 12 hours following surgery. Even though you have done 3 anastomosis, gastrojejunostomy, hepaticojejunostomy, and pancreatojejunostomy, early feeding helps. Provided the surgeon has done a good job, there should not be any complication, which will promote gut resumption of activity and also prevent the translocation of bacteria by early enteral feeding. Okay? And chest physiotherapy and deep breathing exercise prevent pulmonary complication. And maintenance of patient diary helps to monitor the progress and accomplish individual goals. That is for IRAS protocol. If you have to plan what are the goals that to be in the rehabilitation phase itself, and then note down the changes or the improvement that is happening, so that we can see and compare whether we have achieved the goals or not. And what is the pancreatic fistula? What is and how it is managed? If a patient has a pancreatic fistula, how is it managed? What will happen if there's a pancreatic fistula?
Sepsis.
Huh?
Sepsis can lead to sepsis.
Pancreatic fistula means that pancreatic fluids or secretions are coming out, isn't it?
Yes, sir.
So how will they come out? Through the
Forming a
major
trap.
surgery, they will put a drain, isn't it? So pancreatic
Yes.
fistula can result from anastomotic leak and amylase concentration in the drain fluid. That is, amount of fluid will be more, and the drain fluid we can measure the amylase concentration. That will tell you whether there is a leak from the pancreas or not. And if the amount is more than 100 international units per liter, the drain should be kept in place until the drainage totally stops. Most of the pancreatic leaks will automatically get healed by itself. So don't pull out the drain too early, keep it in position. Of course, this is more of a surgical complication. Sometimes they may have to re-explore that. Patients who have fistula may be treated for sepsis and malnutrition in the long run. Okay? That will be our problem if the patient remains in ICU for a long time. Now, what are the other complications and how they are managed? Other complications of the surgery are development of pseudoaneurysm, which will require a CT scanning with a high level of suspicion and monitoring for hemoglobin drop. So if the patient in the post-op has a drastic reduction in the hemoglobin value, then you have to think of a pseudoaneurysm or a gastrointestinal tract hemorrhage. Other complications are post-pancreatectomy hemorrhage, which is best managed by non-operatively with interventional radiology, occluding the bleeding vessel by endo procedures. Then there may be delayed gastric emptying, which may cause discomfort and prolong the hospital stay. And once you diagnose delayed gastric emptying, imaging should be employed to exclude an underlying cause such as an intra-abdominal collection, or management options are long-term nasogastric drainage, correction of fluid and electrolyte imbalance, commencement of proton pump inhibitors, and nutritional supplementation. Then pancreatic exocrine insufficiency can occur post-pancreatic resection, causing fat malabsorption. The requirement of supplemental pancreatic digestive enzymes like tablets are available, which can be given. And patients diabetes after pancreas resection. Total pancreatectomy patients may develop diabetes if they are not diabetic already. And this diabetes is different from type 1 and type 2 diabetes. How is it different? Maybe it rarely produces ketoacidosis as in type 1. Patients are very sensitive to exogenous insulin in comparison with type 2 diabetes. That is the way the diabetes developed after total pancreatectomy differs. It does not produce DKA or diabetic ketoacidosis as it's common in type 1, and it produces more sensitivity to exogenous insulin in type 2 diabetes patients. So you have to be very careful in giving any insulin injections in patients who develop diabetes after pancreatic resection. So it is more common in total pancreatectomy unless an islet transplant also has been performed simultaneously. So if they plan for total pancreatectomy, they invariably do the transplantation of the islet cells also in that patients. The next complication is why jaundice is a concern in patients with CA. Jaundice is most common symptom in patients with periampullary cancer near the ampulla of Vater, and it is considered a risk factor for post-op complications. It could be associated with higher incidence of insufficient post-operative renal function, sepsis, hemorrhage, and mortality. Jaundice causes a retention of acids and bile salts. In long term, it may cause ascending cholangitis and secondary hepatocellular damage. In case of interruption of blood flow, bile acids and salts cannot inhibit the translocation and endotoxemia caused by gram-negative organisms from the digestive tract. And this may cause a pro-inflammatory state, production of cytokines activated by macrophages, subsequent risk of multi-organ failure, including appearance of coagulation disorders. So these are all the complications of untreated obstructive jaundice. And since surgery in patients with jaundice is thought to increase the risk of post-op complications, preoperative biliary drainage was introduced to improve post-operative outcome, even though with limited success. And in severe cases, a preoperative chemodiafiltration to remove the excess bilirubin also has been advocated. And the common points you have to remember in Whipple surgery, as I told in the beginning, one is obstructive jaundice is present or not. So the patients who have severe obstruction features with severe jaundice, they are higher risk patients compared to patients who do not have a obstruction. Like a patient with failure of the pancreas cancer may not have obstructive features at all, even though that is also considered as a CA pancreas case. So that is the first and foremost thing. The surgery planned as a open or lap, depending upon the location of the CA. Third factor is ERAS protocol planned or it is a regular normal protocol. And next is the patient a known DM or not? Whether patient had pre-op chemo or radiation. So patients who have the pre-op chemo or radiation, they have added risk of being immunocompromised. Number one, they may have severe, because the WBC count, RBC count, everything will go down, as you know, after chemo and radiation. And the chemo and radiation produce other complications of drug interactions and other things. So these 5 questions we have to ask in patients who have going to undergo the surgery for this particular procedure. Now, I found these things which are given as a immediate easy remembrance. Preoperatively encourage cessation of cigarette smoking for at least 8 weeks. Treat airflow obstruction with, if there is a COPD or asthma. administer antibiotics, and delay surgery until the patient's respiratory system is clear. Begin patient education regarding lung extraction procedure. These are all the pre-op preparations in smokers. Intraoperatively, limit the duration of surgery as much as possible. Use epidural or blended anesthesia. Use laparoscopy procedure wherever possible. Substitute less ambitious procedure for upper abdominal and thoracic surgery when possible. Post-operatively, use deep breathing exercises, incentive spirometry, use continuous positive airway pressure, use epidural analgesia, use intercostal nerve blocks. So these are all common preparations for any major abdominal surgery. Whereas for pancreatic surgery, it is always commonly general anesthesia with a endotracheal intubation. You have to have large bore IV, arterial line, if necessary, central line. Standard monitoring with a 5-lead ECG, ABP, and the CVP monitoring. Primary anesthetic consideration. Sometimes mechanical bowel preparation may be needed, but in ERAS we don't do that. You can use a combined general epidural, goal-directed fluid therapy, glucose control, blood transfusion management, lung protective ventilation, avoid hypothermia. These are the intraoperative problems. Post-op nausea and vomiting, continue ERAS, continue goal-directed fluid therapy, early NG, Foley, and drain removal, it is ERAS protocol, early post-op nutrition, glycemic control, non-opioid analgesic technique, DVT prophylaxis, pulmonary rehabilitation, and early ambulation. So these are all the things that you can keep in mind for quick recollection, especially during Viva. You can remember all these points to answer the questions that the examiners commonly ask you. Okay. So that is about